Before I get started, one apologetic note. I set aside the weekend to polish up my presentation. I was obsessing about how to get this done in 20 minutes, and of course I'm already wasting time. But little did I know that a 20-inch snow blizzard in the middle of April was going to impede my efforts. So I spent most of the weekend plowing and shoveling snow, missed my plane, and finally did get here last evening. So anyway, where does it snow in the middle of April? Anyway, us Minnesotans, we can deal with it, although I'm not a Minnesota by my background. Okay, home visiting. Every year it's the most popular topic in my prevention science course. Even young students understand the inherent importance of it and the value, especially in families that experience adversity. And they understand the importance of mother-child attachment and why we spend so much time doing that type of work. So even though my presentation isn't directly about home visiting, I hope that I have enough time to show how we have done some of this work that'll be based upon what I talk about today. So with that said, I've wasted 3 minutes, and nevertheless, I thought it was important to share. Although we all know that there are many well-established evidence-based programs in the field of children's mental health, we also know that the effect sizes in randomized trials show these to be fairly modest. And that continues to be a challenge for us. In large part, I think we all believe that the reason for modest effects has less to do with the programs themselves and more to do about the engagement of the people who participate in those programs. Engagement is poor. Participation is low. And this may be the consequence of programs that are one-size-fits-all in nature. It's like in a classroom at school. 30 students, everybody might be taught the same curriculum in the same way. And yet, out of 30 students, there may be only 5 that are average students, and some need more, some need less. Anyway, so that obviously brings us to individual differences. And I'm going to be talking about a particular design that focuses on looking at engagement. But as a prelude to that, this is all part of what was mentioned earlier in the day today, a new emerging field called precision medicine. And I think everybody in this room is probably well aware of this. And from a definitional sense, I'll just read here. It's an approach for disease prevention, early detection, and treatment that seeks to optimize effectiveness by taking into account individual differences in genes, individual differences in environment, individual differences in lifestyle. It comes under many names: personalized healthcare, tailored healthcare, individualized healthcare, customized healthcare, consumer-centered healthcare. The last 10 years we've seen a proliferation of this, and there's a lot of excitement about it, and we believe it may be one solution to trying to raise effect sizes by tailoring interventions or matching interventions to the characteristics that define people's risk. This risk comes in, of course, many varieties. A central premise of personalized care is the active engagement of clients in making decisions for their own care. I grew up in a generation or generations where, you deferred to your doctors, you deferred to your teachers, you deferred to any type of providers that delivered care. But with precision medicine, in addition to its search for the etiologies that will drive healthcare in the future, as we've seen in the area of oncology, where these new pharmacogenetic agents are really changing the topology and leading to better management and cures, hopefully. Hopefully this can be extrapolated to other areas. And in our work at the Center for Personalized Prevention Research, we're of course interested in children's mental health. And as we heard this morning, part of home visiting really focuses on behavioral health care. So I think there are some very important points to be made. So I said that a part, or the opposite side of the coin, for precision health care or precision medicine really focuses on engaging families in their own health care. And for the purpose of this conversation, we'll call that consumer-centered care. Okay? People taking command of their own health care. Now that sounds good intuitively. Yes, I mean, people should have a voice in what happens. But indeed, does that improve outcomes? Does it improve engagement? Does it improve outcomes? Or is it just kind of a new fancy? Well, let's define some aspects of this. What is a prevention effect? Well, preference effect. Well, when a person's given a choice about their own treatment, does that translate into improvement in outcome? Now, the mechanism by which that might happen is through giving person autonomy to choose may enhance an individual's sense of control over the learning process. You can understand that. You have some control over your own health care, and possibly that is the way preference or choice may affect itself. So part of what we do, we're looking at not only preference but need. Can we adapt interventions to help people based upon their needs or their risk factors as well as their preferences? And I'll be talking a little bit about how we do that. But preference involves making decisions, okay? And it can't always be assumed that people will make the best decision, okay? Your choice for an appendectomy attack might be 2 aspirin and rest, when obviously the best treatment needs to be surgery. So people may not often make the best choices. And one way we look at that is to try to understand the decisions they make based upon their values, their traditions, their customs, their worldviews, their attributions about causation. In my own clinical work over the years, working with children who have ADHD and conduct problems, it's kind of the standard to either look at treating with medication or treating with some type of behavioral intervention. And parents always come in with their own point of view on these things. And in years past, not so much today, medication was always something that parents were reluctant to do because of, their history, what they've been told by their parents, what they've read in magazines. And many times this led to months of frustration. So there are many cases where people will choose choices that are not in their best interest. And this has led to an area of study called decision aids. Okay. Sometimes when you walk into your primary care doctor's office, you'll see pamphlets which will talk about various problems like depression or substance abuse, and they talk about how you can screen for this and what are some of the treatments. That's kind of a decision aid. But more innovative decision aids can be presented on the internet in other smart home applications, et cetera, and we look at how to help people make informed decisions. So they're choosing things that are in their best right. So if they have the autonomy and feel self-efficacious about what they're doing, and they're able to look at better treatments, maybe this could be useful. Where I'm going to go with this in terms of home visiting, I know the research had shown at some point that licensed registered nurses produced better outcomes than paraprofessionals. And we can look at I'll be showing in terms of not only those 2 mechanisms, but what about healthcare coaches? What about helplines? There's different ways we can impart information to families, and can they make the choices based upon what's in their best interest? So that gets back to, precision approaches But anyway, decision aids are one way in which we can help. So, first of all, can we prove that giving people their choice in making treatments will lead to more effective outcomes, possibly by increasing their engagement and compliance with the treatments that they have? In traditional, and let me just jump ahead for a moment here, we can study this in 3 different ways. We can use a traditional randomized treatment trial, controlled, and look at preference as a moderator. Giving the person, ask them, do they prefer a certain type of treatment modality, or would they be willing just to accept a treatment that was assigned to them? And then randomize them to a various treatment and see whether or not their preference or no preference moderated treatment outcome. Of course, as you might expect, these type of trials are going to be compromised, because in randomized trials, if people get randomized to a non-preferred modality, they're likely to drop out. And that compromises external validity because you're dealing with a very circumscribed group. Another way, or another design that has been used to examine the impact of preference on engagement and outcome is called the partial randomized preference design. In this particular design, participants with strong preferences are offered their treatment of choice, whereas those who agree with randomization are randomized similar to any other randomized controlled trial. So you have 2 arms. One arm, people are given their choice. In the other arm, they are randomized in a traditional way. So in a sense, we could, rather than using counseling here as the example, we can say people are randomized to a paraprofessional delivering home visiting, or they can be randomized to a nurse or a licensed social worker, somebody who has a little bit more advanced training, okay? Or they can choose. They prefer somebody who looks like them, talks like them, has a similar background as them, a paraprofessional, or they can take a professional with years of experience. And will that make a difference in the terms of their outcomes? Again, remember here what's driving this: engagement. If we can't get people to engage, our interventions are not going to work. A famous line for a movie once said, "If we build it, they will come." We've built it and they're not coming. Okay? So we've got to look at that. And this approach, of course, says because we're not adapting interventions to meet their needs and preferences. You know what I mean? If you go to a store to purchase something and they don't have something you feel comfortable with, you don't buy it. Okay? So it's the same logic here. Now, let me just say that this particular design is somewhat flawed, but it can be heuristically valuable because people in the preference arm of this particular trial, there are not a lot of characteristics of giving people preference that may bias the way they perform. That's why the traditional randomized controlled trial still is a standard. But you can look at the randomized trial, and you find that people who are randomly assigned to a professional nurse or a social worker perform better than people who were in the no counseling group, in the paraprofessional group. On the other hand, when given a preference, you might find equality. When people make a preference, they buy into that particular deliverer of care, and they're going to perform well because it meets their standards, type of thing. And there's other ways we can look at that, but for the sake of time, I just wanted to present that. Kind of the gold standard, and the title of my topic this morning was the hybrid double randomized preference trial. And just for a moment, this will give you an idea of what it might look like. In this particular trial, where it differs from the partial trial, is that you randomize initially to either preference or no preference. So you've equated those two groups on personal characteristics. They're randomized to the preference arm or the no preference arm. And then those in the preference arm are randomized a second time to one of 4 different modalities. So again, using the example that I've already described, they could be randomized to the professional nurse provider. They can be randomized to a paraprofessional. They can be randomized to a healthcare coach who calls up periodically on the phone and assesses status and provides recommendations, strategic goal setting. Or they can be offered a helpline. Those are the four modalities. And you can look at what do people prefer. And of course, in the upper part or in the lower part of the arm, where they're randomized, you look at what it would be in a typical randomized trial. Okay, and let me just read what I put down here as a way of explaining the value of this. The only design that can provide unbiased estimates of selection effects, in other words, mean differences in outcomes between choice and random arms, is this hybrid double randomized trial. But it also allows us to measure preference effects, the conditional benefit that an individual participant experiences from receiving the preferred versus the non-preferred treatment, as well as outcomes, the effective treatment. So, as you look at this, you can see we can collapse all the individual modalities and look at, do people who give a preference do better than people with no preference? That would just kind of inform you about the possible effects of preference. You can collapse over preference and no preference and look at how the individual treatments perform, or you can look at how they interact. Do people in the preference arm prefer A, B, C, or D, or they prefer in the no preference arm A, B, C, or D? So it's kind of powerful design. It controls for cohort effects and other nuisance variables that often can work their way into a design like this. Okay, we did some pilot work. And this was a study, and again, a feasibility study done in Detroit, inner city with many, not many, but a number of children's mental health clinics. And we recruited families primarily culturally diverse, many of whom were economically disadvantaged. So it was a sample that was in strong need of the type of services that were provided. And they were recruited to be in a study in which they would either be given a choice of what type of mental health treatment they wanted for their children, or they would just be given one that they had been randomly assigned to. So we have choice and no choice. Now, as you look at this data, and again, it's very preliminary, it has some heuristic value, but we can't read too much into it. The first thing, and again, the column on the left are the number of people who participated, and the column on the right represents those who completed the intervention. And of course, the most striking thing you see here is the considerable attrition that took place even in this small pilot study. Overall attrition was 25% who did not attend at all, and 40% who attrited during the trial. So there's, again, the problem of engagement raises its head here. Demographic variables did not predict people who dropped out. As we look, and of course, in the no choice randomized group, obviously the numbers who were assigned are equal because it was just done at random. But as you'll see in the choice group, a larger number of people wanted to participate in a home-based treatment. Now, the treatment here was the Parent Management Training Oregon model for parenting. So parents were going to participate in this program. And those who could participate at home were more likely to complete the study than those who were assigned to a group that was done in the clinic or just an individual. The treatment as usual in this case was just child therapy. So it wasn't a no treatment type of control. It wasn't active treatment control, but it was a standard of care that existed at the clinic. So again, this doesn't surprise that a larger percentage of families would rather receive the intervention at home. Although sometimes that's not the case. People are a little bit concerned about inviting people to come to their home. There may be multiple children in a home, which may be distractions. So it's not always the case, but nevertheless, we see this here. Parents, in this case, in the group format and clinical format, were more likely to drop out than parents who were just leaving their children for child therapy sessions. Families randomized to the no choice condition were more likely to drop out. So I think, again, realizing that these are just trends, it tells us that giving parents a choice may improve their engagement and completion. And of the possible choices that they were going to have an opportunity to participate in, receiving the intervention at home was more likely to be the modality of choice. In terms of, again, and I'll just summarize this, it's kind of a busy slide. We examined what type of parents preferred what type of interventions within the choice condition. Parents who scored low on the perceived need to improve parenting, or parents who did not see their child as being at serious risk, were more likely to choose the control, treatment as usual, child therapy, than the parenting programs. Parenting programs involved work on the part of the parent. We examined choice, effective choice on change and observed parenting. Observations were done in a parent's home of their behavior with their children, looking at various types of parent-child communication, conflict, supervision, et cetera, and this was measured at various times, as well as measuring their self-reported efficacy. Within a choice condition, there was a significant modality effect for those selecting the parent program. Greater effective parenting than the no-choice families or choice families who selected treatment as usual. And examine the effect of choice on teacher-reported child behavior. In general, all children improved. However, there was a significant choice times time interaction. Again, pilot data strongly suggests that, number one, it's very difficult to get parents to participate in programs like this. Number two, if they get the opportunity to choose, they may be more likely to complete. In terms of modalities, using home-based delivery seems to outperform clinic and child therapy. I forgot what I started. I just have one more point here that won't take more than 3 or 4 minutes. I wanted to have something to say about home visiting programs, and this will be integrated, both of these, preference-based care and home visiting programs. We do a lot of work in terms of adaptive treatment strategies. And that means adapting a program to meet the needs and preferences of families. That means understanding the factors that predict risk in families and trying to address those in our interventions. And the program Early Risers Skills for Success is a model program that we have used for many years. And it involves a home visiting component, among other components. We have a summer camp. These are all children who are at high risk for developing serious conduct problems. They're screened in kindergarten, and they begin the intervention in first grade for 3 years. And parents get education, children get skill development, teachers learn to collaborate with parents. There are many components, but a very important component is the home visiting component. And the home visiting program is adapted to parent need. And there are 4 levels: no need, low need, moderate need, and high need. The no need, basically, parents just visit and talk about their children's progress in other components. Low need, parents are provided education and information about effective parenting strategies. Moderate need, they receive support, consultation, brief focused interventions. Level 4, case management, community building, and brokering to special services depending upon whether they have chemical health or mental health problems. We begin by performing a strengths need assessment, measuring parenting practices, basic material needs like housing, food, clothing, employment, child care, emotional support, entitlements, and system guides. We also look at physical health, mental health, legal aid, and family functioning. And based upon this strengths and needs assessment, they are classified as one of those 4 particular levels. Some parents are functioning adequately across all those domains. No need. Parents are weak in parenting practices but functioning adequately in other 2 domains. Moderate need, weak in parenting practices, require assistance in obtaining basic material needs, functioning adequately in health and family functioning, and of course high need. They struggle in all those particular areas. Now, what you can do is just provide that intervention based upon need. In an adaptive case, we use stepped care approaches where they're placed at a particular level of need, they're assessed regularly, and based upon an assessment, they can be stepped up or stepped down. It's a way of saving time and finances and also providing people what they need rather than just giving them the standard that they started with. But you can also integrate this with preference, and at each level of need, you can have different delivery systems, and they can choose. Do they want this delivered home visitor by a professional person with experience? Do they want it delivered by a paraprofessional? Do they want it delivered by a healthcare coach? Or do they just want to use a helpline when they run into problems? So it's possible to perform an integration of the adaptive model with the preference model, hopefully maximizing the benefits and addressing not only the needs, but also the choices that people have. So I think it's a pretty innovative doing it. We haven't obviously launched this yet, but it's the next step in trying to, as was said earlier in the day today, understand that a depressed mother may not respond to the program the same way a non-depressed mother will. And a mother who's socially isolated, single parent, doesn't have a community to support, is going to respond differently than somebody else. A mother who's emotionally dysregulated is not going to respond the same way that somebody who's normally regulated. So we have to begin to understand the characteristics of the families we work with and try to use these adaptive strategies and preference strategies to increase their engagement, their autonomy, and basically let them take control over their own care. And we could lecture about that for hours, but that's kind of the approach here that we think is needed. So that's kind of the story here, looking at how we think about preference. Yes, it's important. We still need to learn a lot more about it, the mechanisms that drive it, and how it translates into care in the real world. Thank you.